So, hello, and welcome back to another weekly recap case session of the VMR. I'm Shema, and I'm so delighted that we have 3 cases to discuss. Then I would straightly jump to Monday's case, I think. Yeah. So, firstly, giving you a brief insight to Monday's case, we had a 47-year-old female that was presenting with 4 days of diffuse abdominal pain, nausea, vomiting, diarrhea, and also lethargy for 10 days. She was also altered mentally, tachycardic, feverish, had brisk deep tendon reflexes, and her labs were notable for hyponatremia, hypercalcemia, and also undetectable TSH with elevated thyroid hormones, and her EKG showed atrial flutter, and it came out to be Graves' disease. And after this case, I was like, okay, trying to make 4 teaching points for me that were the most interesting. My first teaching point is actually a metabolic one. As we know, this patient had a mild hypercalcemia. So thinking about the metabolic consequences of hypothyroidism, how it can actually cause hypercalcemia. And this is actually due to what I read, due to high levels of interleukin-6 that lead to an increased activity of the osteoclasts, or these hypermetabolic states, where lead to increase in bone resorption. So this is the cause why we can have hypercalcemia. My second teaching point is actually about tumors that can also cause hypothyroidism. And I selected 3 ones. The first one is metastatic chorion carcinoma. The second one, struma ovarii. And the third one, metastatic thyroid cancer. And like the reason why metastatic chorion carcinoma is causing hypothyroidism is actually the HCG as a glycoprotein, which is secreted. Basically, these glycoprotein hormones like HCG, TSH, LH, FSH, we all have a common alpha subunit, but a distinct beta subunit. So therefore, this HCG is also binding to the thyroid receptor, TSH receptor, leading to hypothyroidism. And the third teaching point is actually about pregnancy, like the same mechanism like in chorion carcinoma. And during the first trimester, pregnant women also have an increase of due to the increase of HCG, we have a transient hypothyroidism during the first trimester. So it's a physiological state. And my last teaching point, there was actually someone mentioning as a mnemonic in the chat about the Wolff-Chaikoff phenomenon. Wolff-Chaikoff, the off, turns off the thyroid. So Wolff-Chaikoff turns the thyroid off. And now I have some questions for you, Robbie. I have read about mixed edema as a complication in hypothyroidism, that hypothyroidism can cause generalized mixed edema, but Graves' disease can also cause mixed edema, but usually localized. What is the reason for that, and generally the pathophysiology?
Oh my gosh, Emma, I love that teaching. There's so much richness there. You taught us about cancer plus thyroid. You taught us about the general base rate of hyperthyroidism, the cool mechanisms that involve beta HCG in pregnancy and in choriocarcinoma, and Chaikoff. Oh my God, so good. I love it. I think your question is a very, very wise one. And I think the root of it is trying to understand trying to make the following simplification. The most common causes of thyroid disease are autoimmune in nature. An autoimmune cause of hypothyroidism is Hashimoto's, and it is a lymphocytic attack on the thyroid gland. The most common cause of hyperthyroidism is autoimmune, and it's Graves' disease, and it's as a result of TSH receptor antibodies. Now, here's the fun fact. If you have one autoimmune thyroid disorder, you're actually at much higher risk of the other autoimmune thyroid disorder. Patients with Hashimoto's have an elevated risk of developing Graves and vice versa. And there's a really nice case report in the American Journal of Medicine, authored by, counterintuitively, a hematologist oncologist that we feature quite frequently on VMR. His name is Dr. Sam Bronfield, and he's been on 3 or 4 VMRs. He authored a paper when he was a resident with a legendary endocrinologist, Ken Feinbold, from which I'm referring to and learned this from. So basically, the key takeaway is in patients with autoimmune thyroid disease, either Hashimoto's or Graves, are at risk for myxedema. And what myxedema is another interesting autoimmune manifestation where there is increased mucinous and fibroblastic deposition, either in the skin or in the eyes. And so I would just encode the observation that myxedema is a phenomenon related to autoimmune thyroid disease, be it Hashimoto's or Graves. And in Graves, it tends to be very localized to a very specific area, which is in front of the anterior tibia. In Hashimoto's, it can be generalized and honestly can be anywhere. Yeah, it's a great question.
And thank you so much. And my second question is, what is actually the main driver for altered mental status in a thyroid storm? Like we learned during the VMR, the hypercalcemia in thyroid storm is actually mild, not that high, as I understood, not that high to cause altered mental status. So what is actually the main driver? Is it more like this kind of symptomatic overstimulation or what?
I don't know. Honestly, I have no idea what the actual answer is. Does anybody here know? I would guess that it's sympathetic toxicity and probably a non-specific mechanism, but I'll tap into the crowd. Anybody have a more clarity than the NOS, like everything's revved up? Nada. Yeah, I don't know, Shema. Did you come across anything in your reading? Nada. Yeah, it's not hard to imagine that, when patients are having thyroid storm, every organ is not working. The liver's not working, the heart's not working, the GI system's not working. So as a proxy, I think we'd assume the brain isn't working, but as to specifically why, I don't think I know. The interesting thing is, how can you guess? And we know that patients' encephalopathy improves with thyroid treatment alone. So you can infer that there's something about the hormone itself that's doing it, probably the way that patients with cocaine or methamphetamine get altered, but I don't know. Stump me again.
And another question that I have is about, I came across the word hashitoxicosis. Can you elaborate on that?
The answer is check off. No, I have no idea. What is this word?
Hashitoxicosis.
Oh my gosh, no. I have no idea what that means. Enlighten me. What did you learn?
I that's the point. I didn't learn. I was like, before
No.
I read more about it, I wanted to ask Robbie because you can explain it much better.
I have no idea. I think you're giving the folks here and folks on YouTube 2 pieces of homework. One is what is the, I can't even remember it. What's the word you just used? I feel like it's had a
Hashitoxicosis.
Hashitoxicosis. What is hashitoxicosis? And why are patients with thyroid storm altered? Folks come here to learn and they leave with more homework than they started. It's perfect.
And I have a last question.
Okay.
We also learned, I remember from one VMR with Aaron, that was about Hashimoto mediated encephalopathy.
Yes.
How common is that actually? Do you know it?
It's very rare. Yeah, so Hashimoto's encephalopathy describes an autoimmune encephalitis in patients who have anti-thyroid antibodies. It's hard to implicate whether the thyroid antibodies are causal in that, because 10% of the population has anti-thyroid antibodies, TPO or otherwise. So the term now has been rebranded to be something like steroid responsive encephalopathy of some kind. So yeah, I've actually seen a case of it once a long time ago, but it's very, very rare. Yeah. Amazing. This is Shema's masterclass of words I will never ever understand, one of which was really helpful, Chaikov. The other 2, I have no idea, but I can't wait to read about them and learn them. And if anybody else does, please chime in. Would really appreciate your thoughts. Any questions about this case before we move on? Anybody? Awesome teaching, Shema. Thank you for the brilliant pearls and exploring the gaps in our knowledge. I can't wait to fill them. All right, Maddie, take us away.
All right. Yeah, Shema, that was a beautiful recap and awesome teaching points and some homework to take away. So you covered everything. So I get to present Tuesday's POCUS VMR, which was presented by Dr. Daniel Restrepo and discussed by Ravi and AMK, really a phenomenal case. So the short summary is that this was a 55-year-old man with a history of hypertension on valsartan and alcohol use disorder who presented with dizziness upon standing and was found to have a narrow pulse pressure and fluid refractory lactic acidosis. So point of care ultrasound was performed, which was reassuring with normal cardiac function and a non-distended IVC. The patient was ultimately started on high-dose thiamine, which resolved the lactic acidosis. So in this case, the final diagnosis was thought to be a relative thiamine deficiency causing a type B lactic acidosis in the setting of alcohol use. So for the first teaching point, I thought a really important point that was highlighted in this case was how do we approach shock? So I kind of wanted to go through like a high level approach to that. So as we all know, shock is the state of low organ perfusion and tissue hypoxia. And the types of shock really fall into four main categories that AMK walked us through during the session. So the first is hypovolemic, cardiogenic, obstructive, and distributive. And just to go through some short examples. So for hypovolemic, you can think of this as, is it a hemorrhagic cause or a non-hemorrhagic cause? And so non-hemorrhagic can be, for example, loss from the GI tract. And some clinical signs that kind of point towards this are, is the patient responding to fluids and is there a narrow pulse pressure? For cardiogenic, some of the causes of the many things that can cause this are a myocardial infarction, an arrhythmia, a cardiomyopathy. And some signs that point to this is, an elevated JVP, for example. And then obstructive causes, some examples there, like a pulmonary embolism, cardiac tamponade, tension pneumothorax. And then lastly, in the distributive bucket, you can think of a septic shock, anaphylaxis, neurogenic. And actually AMK mentioned kind of acute adrenal insufficiency, which I actually hadn't thought of in the shock category, which was interesting. So besides those kind of four buckets, a really important point that came away from this VMR is that point of care ultrasound can be really useful to evaluate which type of shock is occurring, and specifically ultrasound of the IVC and the heart. So we talked about how if the IVC is distended, which is normally above 2 centimeters, that's generally like a proxy for an elevated central venous pressure, which you can think of in types of cardiogenic or obstructive shock. Then ultrasound of the heart, you can see, look for like the appropriate squeeze of the ventricles. You can see signs of pericardial effusions. And one sign on ultrasound that was new to me is something called the D sign. And I'm actually going to share my screen and show a photo of this because I think it really helps to illustrate that. Give me one second. Can you all see this? Yeah, okay, great. So the D sign indicates elevated right-sided heart pressures. And you can see that normally the left ventricle on ultrasound should be shaped as an O in the peristernal short axis view. But when you have elevated right heart pressures, you have an enlarged right ventricle, which pushes on the left ventricle and causes this D-shaped left ventricle. So that's kind of the D sign, which you can see in types of obstructive shocks. A mimicker of that would be like elevated pulmonary hypertension, because that would just cause like an enlarged right ventricle. All right, so that was kind of the first teaching point, just walking through the different types of shocks. Oops, sorry. And so the next thing I wanted to go over was the other key part of this case was that the patient had fluid refractory lactic acidosis. And so we talked in the case, they mentioned type B lactic acidosis. So this kind of prompted me to understand, how do we approach lactic acidosis? What is type A? What is type B? Because that's always kind of confusing to me. So in lactic acidosis, you can kind of think of, is there too much lactate being produced, or is there an issue with the processing of lactate? And that really relates to kind of the distinction of type A and type B. So type A lactic acidosis, I want to highlight, is much more common. And the main mechanism is that there's tissue hypoperfusion from one of the types of shocks that we just went through. And normally patients would have, the clinical manifestations of shock, like low systemic blood pressure, cool and clammy extremities. So that's type A. It's like low tissue hypoperfusion, often in the setting of shock. Type B is much less common, and the main takeaway is that in contrast to type A, type B, systemic hypoperfusion is not apparent. And there's a lot of different types of mechanisms, but oftentimes the causes can be liver disease, so you're unable to metabolize the lactate, medications like metformin, malignancy, and then thiamine deficiency, which was the cause in this case. It kind of relates a little bit to the biochemistry, because thiamine is a necessary cofactor for an enzyme that converts pyruvate to acetyl-CoA. So if you can't do that, pyruvate is then shunted to lactate. So the summary here, so teaching point 1 is that to approach shock, you want to think of the 4 categories: hypovolemic, which can be hemorrhagic or non-hemorrhagic, cardiogenic, obstructive, and distributive. And point of care ultrasound, especially at the heart and at the IVC, can be really helpful in distinguishing those. And then 2 is lactic acidosis can be classified as type A and type B. Type A is much more common and is due to tissue hypoperfusion, whereas type B is unrelated to systemic hypoperfusion. So when I was going through this case, Ravi, a question for you is, I was wondering if, and actually Ravi is also on this call, do you think there was a component of both type A and type B lactic acidosis in this case? Because there was definitely type B because thiamine deficiency was present, the patient improved with thiamine, but there were signs of, there were clinical signs of shock, both from the physical exam, there's cool clammy skin, and then also some of the lab values, there's an AKI. So do you think there was also a component of type A in this case?
Gosh, I would love Ravi to weigh in, because I heard of their the brilliant co-discussion at the AMK. I think that your teaching is superb, and highlighting the importance of using the word "and" sometimes and not "or." Sometimes patients can have both, and I think, is it possible in general for patients with thiamine deficiency to have both? Absolutely, but I'll lean on Ravi to tell us what he was thinking in real time about that possibility in this case.
Oh, yeah, absolutely. I agree with Ravi on that it was probably a multifactorial contribution. So you're absolutely right. I love that you're breaking it down into type A and type B. Actually, there's a schema that Ravi had made also, and then I had sort of made my own, and then also made one on thiamine deficiency, because Rafa, one of the early cases that he presented a long time ago, I don't remember, Ravi, if you remember, it was thiamine deficiency, so wet beriberi. So in this case, there wasn't any sign of beriberi, and somebody astutely had mentioned there wasn't a wide pulse pressure that you would get with that. So the narrow, like you had picked up on one of your teaching points, the narrow pulse pressure, it goes along with hypovolemia. And if you look at the POCUS image, the IVC being narrow and collapsing, so there was an element of hypovolemia. So maybe there was type A circulatory dysfunction. There was also some, if I remember, liver issue as well. So clearance can be impacted by that. And then thiamine deficiency. But, the patient wasn't in the full throes of thiamine deficiency. There was no sign of any cardiac dysfunction, anything like that. But after that VMR, you always learn something new. I did Google thiamine deficiency and shock, and it came up that in septic shock, occasionally we do give thiamine in that presentation. So maybe it has some relevance there. So maybe there was a background of something going on, and then there was dehydration. And then what I picked up on, this was the second VMR. Remember student VMR, there was a patient with alcohol use as well. And then we stopped, and we sort of did a walkthrough of alcohol and its related features. So here, there's another schema that Ravi had made with alcohol use, or I guess signs that there's alcohol use. What kind of complications can you have? So thiamine deficiency is one of them. So that immediately we picked up on that, but really didn't link it towards the end that thiamine deficiency was causing that. But alcohol can cause dehydration, hyponatremia, electrolyte dysfunctions, also renal injury as well, or it just changes the ability to absorb sodium and so on, and affects the channels and so on in the kidney. So yeah, I think dehydration, the alcohol use, and circulatory dysfunction. Could there be some infection bubbling under the surface? Because I wasn't quite sure what else was going on if thiamine completely was able to reverse it. But that's the first time I've heard of thiamine deficiency causing refractory. And the key was, like you mentioned, refractory shock. So the only time I've come across that, cortisol deficiency, PE, with septic shock, that's severe. You're in the severe end stage, or the worst part of septic shock. Maybe patients refractory and needs pressors in that case.
Gosh, I love this conversation. I think that one thing that you can take away from this case, Maddie, is how the schemas are flawed in that they have one arrow that guides you down one pathway. But in both scenarios that you just talked about, you can give us a great overview of shock and a great overview of lactic acidosis. And in both circumstances, I bet you the vast majority of people have both. For example, in patients with shock, I don't think I've ever seen a patient with septic shock who also didn't have hypovolemia at some degree. It's also not uncommon for patients with septic shock to get a septic cardiomyopathy and have a cardiogenic component too. So now you've seen an overlap between sepsis and hypovolemic and cardiogenic. And believe it or not, any inflammatory disease is a trigger for thromboembolism. So that's how you can get sepsis and obstructive shock with PE. And once you look at this category, you're like, wait, I know that these are each separate categories, but nobody has told me that my patient's immune to not getting simultaneous diseases from each of them. And I bet you that anybody who's sick enough to get septic shock probably has some thiamine, like a functional thiamine deficiency, like type A and type B, probably coexist more than we realize. But I think in most cases, honestly, even though there's contributions from multiple categories, we lean only on one because it's so dominant. Like it's 80-20. Most patients with sepsis have 80% septic shock and 20% hypovolemia. But the things get tricky when it's 50-50, you know, and you're like, oh, wow, like their lactic acidosis is because they're not perfusing, but like there's still a significant chunk left even after I give them fluid. So I bet it's hypovolemia and from the shock and thiamine deficiency.
Yeah, two other features I want to point out. Yeah, I don't know, along the way in teaching where people learn that lactic acidosis means sepsis. So everybody just thinks sepsis and throws fluids, and it's not always an indicator that you're under perfusing. But in this case, it could be. But again, it could also be an indication of thiamine, and so type A and type B. And the other thing is with this thiamine deficiency, I don't know, it's probably going to change my practice if I do come across somebody like this to consider it. So definitely I learned a lot from this case. And regarding that biventricular, the parasternal short axis view, I did learn something interesting from Dr. Restrepo. He calls it the bagel and the croissant. So the right ventricle is the croissant and the bagel is the left ventricle. But when you get that croissant turning into a figure 8 double bagel or a bigger bagel for the right ventricle, then you know there's right ventricular volume overload or increased pressures on that right side.
Yeah, there are so many amazing focus pearls from that VMR. Robbie, you already touched on this a little bit, but another question I was thinking about is when you are presented with like fluid refractory shock, what should we be thinking about? And I know in the VMR you talked about, you know, maybe a massive hemorrhage. So are you kind of losing more than you're putting in, or is this kind of like an end stage of a septic shock? So I just wanted to ask, like, what else kind of comes to mind when you think of fluid refractory shock?
Oh, you're asking me?
Oh. And Robbie, and just anyone's, yeah.
Yeah, I think the two where, you know, shock, that walkthrough of shock that you did is incredibly powerful, and it just puts you way up top in your learning there. So being able to go through that differential of shock is very helpful, because you'll encounter hypertension and shock quite a bit in residency. So a lot of times you have to learn to switch gears. For some reason, sepsis, we get patients coming in low grade temp, maybe a little white count, and they smell, walk, talk like sepsis. But sometimes you may have to consider or move out of the category of septic shock into obstructive shock, cardiogenic shock, and so on. That's where POCUS may help. But yeah, I've had to, using POCUS, I have determined the septic patient to be actually suffering with massive PE. So PE is one where, you know, I've had patients or took over patients where lots and lots of fluids was given, the patient was mildly fluid responsive, but then the blood pressure kept dropping. Or in the case of adrenal insufficiency, so there the patient has sympathetic discharge trying to compensate, but then you need cortisol to help with the epinephrine and the upregulation of the receptors, so the epinephrine can bind and cause the vasoconstriction. And then severe sepsis, where you need pressors in that case. So the inflammatory cascade is just too far gone, and you need to use pressors. But just like Robbie had mentioned, you do need volume before you implement pressors. So they always tell you in ICU, don't just start pressors, give enough volume so the pressors can work on that volume. Otherwise, the vessels just vasoconstrict and there's no volume to help support perfusion. Robbie, any additional thoughts?
I think you've laid it out so well, and you might come at it from the sense of saying, well, okay, volume refractory shock. What does volume fix? Hypovolemia. All the other causes of shock are still fair game, you know? And I think that's all. And I think it's crazy that it's that simple and it's so hard to enact it in real life. But I would say all causes of septic shock are volume refractory. All causes of hemorrhagic non-plasma loss are fluid refractory. All causes of cardiogenic shock are definitely fluid refractory, and all causes of septic shock are fluid refractory. So you treat this tiny little part of shock, which is hypovolemia, and hypovolemic shock in the United States is exceedingly rare. Well, hypovolemic shock as an isolated cause is when patients get massive diarrhea from cholera or things of that nature. So I think what you're seeing when we talk about this question is actually a different question when it comes up on the wards and in real life. The question often is this patient actually in shock, or do they have a little bit of hypovolemia? And it's not uncommon for somebody to have soft blood pressures from being mildly volume down, and then you're like, oh, okay, they're not in shock actually. Like the patient who comes in and who has a little bit of a fever, has a whopping infiltrate and a white count, you're like, they're pneumonia, but their blood pressure is low. And you're like, oh, do they have sepsis? But if you give them a little bit of fluid, and do they have septic shock? You give them a little bit of fluid, you realize, oh, the reason that they were hypotensive wasn't because they have sepsis vasodilatory physiology, it's because they haven't had food for like 3 or 4 days. So that's where it comes to play. So hypovolemia is a common complication of the other disease processes that can result in shock. But so fluid responsive hypotension is very, very common. Fluid responsive shock, almost unheard of in the United States, because many people who are hypotensive don't actually have shock and have 3 or 4 liters of hypovolemia, which are easily fixed in the first 5 hours of taking care of them. The small fraction of patients who have persistent hypotension despite that, 70% of them have septic shock in the United States, 15% of them have cardiogenic shock, and the other 15% have obstructive shock in the US. So why does fluid refractory come up? It's because most people who have soft blood pressures are hypovolemic. But once you actually enter the world of sepsis, it's very rare for additional fluids to actually be helpful. Once you enter the world of true legitimate shock, your fluids are probably not going to be very helpful, unless the patient is obviously having overt hypovolemia in front of you with massive, usually GI losses, but sometimes also renal. Yeah.
And again, here, the definition usually of shock, I guess, you after like a few liters of fluid, if you're still refractory, if you still have low blood pressure, you've moved beyond the hypovolemic, I guess, category.
Yeah. Oh, the world. Maddie, you've helped out so many people by bringing this conversation up, because it's such a lactic acidosis being sepsis, as Robbie talked about, is a big source of confusion. And what is shock? Basically, when we define shock properly in research studies, we've eliminated hypovolemia. We've like treated it aggressively. And so that's why in the United States, fluid refractory shock, almost every kind of shock is fluid refractory, strictly speaking, because you've already done your job of excluding the fluid sensitive part. Y'all,
right, yeah, that's helpful.
Yeah, go ahead. Thursday was amazing. I find it ironic that I'm discussing it after Maddie eloquently discussed it in real time. And the crux of the case was a patient who presented with seizure and was found to have a brain mass. And instead of focusing on the initial part, I think it's a great opportunity to reflect on a general approach to brain masses, which goes to show you that the approach to brain mass cannot be agnostic to what's going on peripherally. It's profoundly impactful to know what's happening in the body when you're approaching a brain mass. So I'll give you some examples that weren't related to this case. And if I tell you your patient has a brain mass and as a lung mass, you'll probably tell me that whatever's happening in the lung went to the brain. Correct answer. And your patient has a brain mass, and like we discovered on Thursday, your patient has HIV, you'll be like, okay, the differential diagnosis is very different in a patient with a brain mass with HIV. So learning point number one in approaching a patient with a brain mass is you have to have a survey of the periphery and understand what is going on in the rest of the body. And that survey can be a focus on what kind of malignant diseases are happening in the body, like lung cancer, or what kind of immunosuppressing conditions like HIV. That's the most important thing. There are very few autoimmune diseases that cause brain masses. They're definitely, the list is very long, but the incidence is very low of each of them causing an actual brain mass. So in a patient with HIV, the same tension exists. Is it cancer or is it infection? But again, most infections in patients with HIV and cancer, most infections in patients with HIV don't form masses. They form like meningitis, encephalitis, like JC virus or cryptococcus. So the real tension in real life, as Maddie and I were talking about, is it toxo or is it primary CNS lymphoma? Like that's really the overwhelming conversation in these patients. But of course, it could be another infection or it could be another cancer, but those two things loom large. And the best way to know is a brain biopsy. The yield of a brain biopsy to tease out the situation is literally 99.999%, according to one study. It was actually 99%, but it's way more fun to say that because it reminds me of Reza on RLR all the time. So brain biopsy will tell you the answer, but the question is, can you get the answer without having to poke a hole in the patient's brain? And the answer is yes. The next best step is response to therapy. So patients are presumed to have toxo if they have toxo IgG positivity. So the algorithm often is my patient at risk for toxo? And the answer comes from recognizing that toxoplasmosis in patients with HIV is a reactivation disease. You have had toxo all your life, as evidenced by your IgG being positive, and you reactivate it. So if your toxo IgG is negative, means you don't have toxoplasmosis, the probability of toxo brain abscess is nearly zero. So if I want to know a single test in a patient with HIV and CNS and trying to tease out as a toxo or lymphoma, I want to know the toxo IgG. And if it's negative, I'm done. It's primary CNS lymphoma with some gaps remaining to make sure it's not something else. But if the toxo IgG is positive, you haven't moved the needle. You've just proven that the patient could have toxo. And the next step is to see how they respond to toxoplasmosis treatment over 2 weeks. Cool? Yes, Shayma, toxo IgM is not helpful in this scenario. Really good question. So that's the kind of like summary of it, but what are your nuanced tools? So pay close attention to the MRI. 70% of patients with toxoplasmosis have multiple lesions. If you have one lesion with toxo, which occurs in 30% of patients, it's usually not too large. It's usually less than 4 centimeters. Toxo doesn't grow in one space and become massive. If you are catching a solitary lesion in toxoplasmosis and it's only one, it has to be small. Because if you just let the natural history go on, it spreads somewhere else. It doesn't get big. It peels off and grows somewhere else. That's why most people have many. But if you catch the disease early, you might see only one, but it'll be small. In contrast, primary CNS lymphoma, it's about 50-50 between solitary and multiple, and the solitary can be massive. Your LP can be helpful because in toxoplasmosis, you can get a toxo PCR, and if it's positive, it's super helpful. It's diagnostic if it's positive, but it's only 50%. In patients who have the disease, the LP is only positive in half of them. So the sensitivity is pretty low. In terms of your LP tools for primary CNS lymphoma, you can get cytology, which is only positive in 20% of patients, and an EBV PCR. If it's negative, it's super helpful. If it's positive, plus minus. So you're seeing now with this teaching, which is utterly useless, how complicated it gets. Like you cannot remember all these things. So what is it our job to really remember? HIV plus brain mass toxo plus primary CNS lymphoma. What's a streamlined algorithm? If your toxo IgG is negative, it's primary CNS lymphoma. If your toxo IgG is positive, then it could be either of them, and you should give empiric therapy for toxo and see what happens. And as you get more and more reps with this space, you can start to add on the nuances that I talked about, including the LP results for each disease, scrutiny of the MRI for each disease, but none of those things are good enough to really prevent you from doing empiric treatment. Cool? Questions, thoughts? Oh, Alex, do you want to ask your question out loud? It's a really, really good one.
Sure. Yeah, so you mentioned a really helpful teaching point about the utility of an LP for diagnosis of toxo. I guess my question was, when you see this large lesion on head CT or on brain MRI, are you ever concerned about, I don't know if it's just a theoretical risk or if it's a true risk of herniation when you do the LP because you have a larger intracranial pressure from the mass?
Yeah, it's a phenomenal question. I think that's why a lot of people don't get LPs, and you often don't have that information. The truth is that the risk of brain herniation in these patients is very, very low because they often don't have elevated ICP to begin with. So yeah, I think we avoid the LP, and we certainly, because we have other tools. I've never been in this situation, honestly. I think so yeah, I can't claim to know from personal experience, but I think the facts are LPs aren't often obtained, but the risk of brain herniation, even with a mass, isn't that high. It's usually when there's that mass is in a bad place, like the fourth ventricle compressing and whatnot. Yeah. Shema, well, you want to ask your question out loud?
Sure. I was asking myself whether the imaging finding can help us to differentiate what kind of mass it could be. I mean, if we have an HIV positive patient and we see the CD4 count, this can help us to narrow the differential. But I'm asking myself, I know for toxo, it is usually ring enhancing. How is it like with primary ZMS lymphoma or the other lesions? Like when we think about JC virus, I'm actually always thinking of these demyelinating lesions. So yeah, I don't know.
No, it's a great question. I think in JC virus, you don't have any masses and you don't have any enhancement. There's no enhancement and no mass. And both toxo and primary CNS lymphoma, you should have complete ring enhancement. There are some subtle MRI features. So primary CNS lymphoma often has a restriction, does not have a restriction on diffusion weighted imaging, and toxo does. But these are not very powerful. They're like subtle clues. Yeah, it's a tough space to be in. And, the algorithm often is you try toxo treatment. If the patient doesn't get better, you do a brain biopsy. So it's not uncommon. And just to be clear, the complications of brain biopsy are not that high. It sounds from the layman's perspective as very scary and risky, but it's not that bad. Especially if your patient has a brain mass and you haven't been able to figure it out for 2 weeks. At that point, geez, often usually a simple decision to do it. Any final questions, y'all? What a week. What a week, from shock to lactic acidosis to the many offs of thyroid disease and thyroid skin manifestations and cancers causing hyperthyroidism to brain abscesses and toxo. I learned a lot with only half the VMR lineup. So super excited for next week. Thank you all for hanging out. I'll stop the recording and hang out with the crowd here.